Hello everyone and welcome back to the Diary of an Endodontist. Today we'll be talking about external cervical resorptions, so stay with me. This patient was referred by his orthodontist during Invisalign treatment. During that treatment, the orthodontist spotted the gingiva on the palatal aspect of tooth, the upper left one. It was a bit enlarged, it was bleeding, and there was, on probing, he could spot a small cavity. He then took an X-ray and saw that the cavity was quite big and referred to us to see if it needed any root canal treatment. The patient was completely asymptomatic when I saw him, but the cavity was slightly different. It was very discolored. It was supragingival part of it, and I could clearly see with the probe going quite deep. The tooth was responsive to the endofrost, and it was not sensitive at all at home, was not tender, was completely asymptomatic. So the patient had no complaint whatsoever, and the tooth itself was not discolored. I then take a CBCT just to see the extension of that external cervical resorption. And I could see that it was the CJ junction, it was going there, was slightly infra that part. It was completely supraosseous, as you can see here, and it was part subgingival as we knew it. It was not too close to the pulp tissue, so I knew at that time that I would plan a composite filling instead of bioceramic. If it was infraosseous, then I would have chosen bioceramic filling because that will stimulate the bone to regenerate. However, as it is supraosseous, it doesn't matter if it's slightly subgingival, the composite filling will work really well. In my opinion, would be the best material for that area because we can polish properly. When you plan to do this case, a nice flap is important so you can expose the whole area of that cavity. It's also important for you to control the moist in that area because if you are doing a proper composite, you need that area to be completely dry before you bond. Bleeding, you need to control, so I would advise you to use magnification because with magnification, you can see a little bit of moist, but you won't allow that moist to come. If you can dry and make it very, very dry, fantastic. In that case, I could see what I was doing when I was etching and bonding and putting my flow composite and also doing the permanent composite without any interference of any subgingival fluid or bleeding in this area. Just to go back a little bit here, as you can see, it's slightly reddish, but there is no pulp exposure. If there is no pulp exposure, you don't need to put any bioceramic. Unless the tooth was a bit sensitive, it was like a very thin dentin covering that pulp. And I think in this case, there was enough dentin in this area, so normal composite would be better to give more stability and avoid any leakage in this area in future. Remember that part of that filling will be slightly subgingival still. So you need to have a very good bonding in this part of the composite, well, the whole part of the composite, please. So it doesn't allow any coronal leakage in future. After that, after polishing this composite, it's time for the flap to come back and the sutures to go in. You can choose any suture you want. I normally put polypropylene suture, but in this case, the patient was going away and I chose the Vicryl, which is an absorbable suture and is better because the patient doesn't need to worry to come back and to have these stitches removal. However, I always prefer to see my patients, always prefer to see and control the gingiva and the healing. But in this case, I was completely happy with the situation, was very, very polished, and I just explained to the patient how to keep that area clean and that these stitches would come off in a few days. The X-ray, final X-ray, is important for you to see as well, just to check if the margin of that filling is correct, if there is any void in the filling. And if you have the opportunity, monitor this patient or let him know that he can always contact you if the tooth becomes sensitive. However, what I think is if you bond it properly, it's less likely for that tooth to be sensitive. If there is a problem with the bonding and your technique, then you would probably expect post-op sensitivity more often. So bear in mind about that when you are choosing your technique, your bonding technique. I hope you have enjoyed that, and please stay tuned and subscribe to our channel because we have lots of different topics coming up. You take care.